count on that next line of therapy because your patient may not get there.
Maybe it's everybody else but you.
Sure.
I haven't looked, but I feel the same way about my
I don't
data
have a
set.
big enough ego to believe that, Greg.
Like even in the triple negative space, I quote the same data too.
Yeah.
Like 50% dropout from first line. But I'm like, in my practice, is it really 50%?
But I mean, I think there is somewhat of a bias of who comes to a clinical trial site, et cetera, compared to, other places maybe too.
Yeah. ILD concerns in that population?
Yeah,
Hormone
I mean,
receptor positive?
I think you've got to be concerned with ILD when you use trastuzumab deruxtecan. I mean, that's just wise and smart, and we need to be concerned. But I think we're doing much better. Knock on wood, I've never had a fatal case of ILD, so I'm going to try to keep that up. I think really the important point is to educate, community oncologists that may be seeing all tumor types, that this ILD is different than what we think of as ILD with like a checkpoint inhibitor, where you don't really care much until it's grade 3, and you're certainly not holding the drug at grade 1, right? So I think really just being vigilant around recognizing that it can happen. It's more common to happen in that first year, less common to happen after the first year. But I'll have to say, I only had one grade 3 ILD, and it wasn't in the first year. So I'm vigilant about ILD always. I think it lets us know to not space out our scans too much on trastuzumab deruxtecan. I scan every 9 weeks, every 3 cycles.
Okay, makes sense. Especially, I do also, for patients I'm concerned about, I would probably go sooner, especially if there was a question of ILD coming into it. I've had patients who were questionable ILD on Abema.
Oh, okay.
And it's resolved. That patient, I am doing a 6-week scan just to make sure, because again, it's not really fully flushed out.
Yeah, sometimes it's hard to get the CT scans through at a more frequent than every 8 weeks unless you have a good reason. Now, if anybody has shortness of breath or any symptoms, you certainly can get a CT scan at that point. But
yes, so that it's very concerned. The other important point is, and I think the French group had a presentation last year, ESMO, about what it can look like on a scan, and it brought to my mind that ILD can look like pneumonia. And so you always have to keep in your mind, if this patient is on T-DXd, and I think the one patient I've lost with that is she had really, the imaging looked like it's a consolidation, like it's pneumonia, and she went to a hospital that really wasn't affiliated with us.
Right.
And the reports we were getting when I speak to the doctor, she has pneumonia and she's on high antibiotics. And it just turns out she wasn't responding. And it was a little bit too late to try to rescue her because of that.
yeah,
All right.
low threshold to think of steroids.
Low threshold.